Hey guys, my name is Megan, and this is my critical appraisal on the study titled The Effect of Amlodipine on the Survival of Patients with Severe Chronic Heart Failure Due to Non-Ischemic Cardiomyopathy. So, first we looked at the validity of results by addressing if the intervention and control groups started with the same prognosis. The study indicated that patients were randomly assigned in a double-blind manner, however they didn't really give much other information on things such as sequence generation, for example. Similarly, there was no mention of allocation concealment, so I would need a little bit more information on this before I'd actually feel comfortable saying study methods were adequate. In regard to the two study groups, both groups were pretty similar with respect to age, sex, disease characteristics, etc., as you can see here in Table 1. So this would lead me to be a little more confident that the randomization was actually done pretty adequately. So, like the randomization procedure and allocation concealment, I wasn't completely comfortable with the amount of information given about the blinding in the study. All that was really indicated was that the patients were assigned in a double-blind fashion, but there was no definition of blinding or any indication that blinding was even effective. Next, we looked at the study groups and if they were balanced at the study completion. We can determine follow-up was complete because everyone who started the study was included in the analysis. In respect to the trial being stopped early, the study didn't really indicate an intended length for the study, but they said they would continue until 264 deaths occurred in the placebo group. However, at the end of the study, there was only 262 deaths, but it didn't explicitly say that they stopped early, so it's pretty safe to assume that the trial went the intended length. The study was analyzed using an intention-to-treat analysis, so basically all patients were analyzed based on the group that they were put in at the start of the study. We can confirm this by looking here at Table 2, which gives the number of participants in each group, which was 827, which is actually also the number of patients that were allocated to each group at the start of the study. Next, I looked at what the results were. There was actually an increase in the risk of death associated with the treatment group, so it wasn't appropriate to determine the relative or absolute risk reduction. The hazard ratio, however, reported was 1.09 for the primary outcome, which was death, with a confidence interval of 0.95 to 1.37 and a p-value of 0.17. And, as we know, a confidence interval that crosses the line of no difference, or 1, is statistically insignificant, which would be the case here. Finally, I looked at how to apply the results I found to clinical practice. I felt that despite the fact there were actually a lot of criteria that had to be met for inclusion in the study, the patient population was represented pretty well. However, since we were a little iffy there at the start of the study about the validity, just due to the lack of information provided about blinding or randomization, these results should probably be applied cautiously. Also, the primary outcome was death from any cause, and the secondary outcomes were cardiovascular death and hospitalizations. So, since there was no benefit with treatment and there was actually an increased risk, I calculated the number needed to harm, which worked out to be 53, so that just means that 53 patients needed to receive treatment in order for one death to occur. Ultimately, as you could probably guess, I would not recommend amlodipine for patients with non-ischemic heart failure as there is an increased risk of death associated with its use opposed to a protective effect.